Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. With me today is Dr. Dmitry Nepogadyev, who is the co-chief investigator in the GlobalSurg-CovidSurg consortium. Dmitry is based at the University of Birmingham in the UK. Welcome to our interview.
Thank you very much for the invitation. It's very generous.
Pleasure having you here with us today. We spoke with one of your colleagues and co-investigators, Anil Bangu, about a year ago when you were just launching the collaborative and talking about your preliminary data. Now we've reached the point where you've had this wonderful article published in Anesthesia 2021. I'd like to focus upon that publication, the timing of surgery following the SARS-CoV2 infection. So perhaps we can just rewind a little bit, some of what I discussed with Anil last year. Tell us a little about the collaborative, how it started, and how many patients you have from which locations.
GlobalSurg Collaborative is a global research network that's been formed by surgeons really from all around the world. We've got representation in the steering committee from over 100 countries. And it's a community effort to gather real-world evidence to inform better care during the pandemic. Over the course of 2020, we ran 3 different studies, and we've collected data on a total of 190,000 patients. And over 2,000 hospitals in about 116 countries have taken part. United States has been a big part of that. In the most recent study, there was over 10,000 patients entered from the United States from, I think, around 60 different hospitals. So we're very grateful to everyone who's taken part. Everyone's contribution is really important in sort of generating this real-world evidence.
Well, congratulations upon this formidable and super impressive undertaking. To my naivete, it seems like it's probably the largest collaborative of that many patients assembled in 12 months, at least during my career. I'm not aware of another one like it. So with that size data pool, a lot of good information can certainly be gleaned. It's a voluntary registry. Does it require local IRB approval, by the way?
So that depends on country-specific regulations. In the United States, most hospitals have managed to get a sort of expedited IRB approval with a waiver for patient-level consent. That has varied from hospital to hospital. I have to say I'm very grateful to the team that coordinated the study in the United States, who are based at MGH. Dr. Kafari and his colleagues have really made a massive effort to push this study forward, and really can't overestimate the support they gave to sites around the United States.
Well, that's great. It's good that you had that support from MGH. Tell us a little bit then about your original article on the timing of surgery in your international prospective cohort study. How many patients were in that group and what did you find?
So I guess to start with the background, we had an early publication last May in The Lancet, which was just based on the first 1,000 patients we collected data on who had SARS-CoV-2 infection around the time of surgery. And I'm sure some of your listeners will be familiar with that article. It showed that patients who develop perioperative SARS-CoV-2 are at high risk of postoperative complications and death. So as time went on, we wanted to understand how long do those risks persist for after patients have had SARS-CoV-2 infection? Is this something that is limited to the acute infection, or will these patients be at increased risk for a period of time after they've been infected? So we really set up the latest study, GlobalSurg-CovidSurg Week, to prospectively address this specific issue. So we wanted to capture data both on patients who had acute SARS-CoV-2 infection, sort of ongoing symptoms at the time of surgery, patients who had previous SARS-CoV-2 infection that had resolved, and also patients who didn't have any SARS-CoV-2 infection. So that would give us the comparator to be able to understand and benchmark patients' outcomes. in the end, we've collected data for this study for about 142,000 patients, which sounds like a huge number, but actually that was probably the number of patients you need to address this question, because we found that the rate of preoperative SARS-CoV-2 is relatively low at the moment. It's probably about 2% of patients have had previous infection when they come for surgery. But that's likely to increase over time as obviously more people have survived the infection, and maybe as surgeons are more confident to taking these patients to surgery. And so our key finding was that when we stratified patients by the duration of time between SARS-CoV-2 infection and surgery, what we found was patients who had active SARS-CoV-2 infection at the time of surgery were at the greatest risk in terms of their mortality risk. And patients who were operated between 0 and 6 weeks after SARS-CoV-2 diagnosis were still at increased risk, persistent sort of high increased risk of mortality. However, by the time patients got to 7 or more weeks after infection diagnosis, those patients' mortality risk returned to baseline, the same as the risk in patients who never had SARS-CoV-2 infection. So what that suggests to us is that if you have a patient who's had previous infection, if possible, and of course it's not always appropriate, but if possible, it's likely patients would benefit for that delay of around 7 weeks between infection, diagnosis, and surgery to minimize their risk of mortality.
Can you give us a rough estimate of what those mortality rates may have been in patients who were actively infected versus 1 to 6 weeks versus 7 or more weeks out?
So the baseline risk, this is in patients who've never had SARS-CoV-2 infection, was 1.5% mortality. This is bearing in mind we're including all types of surgery, elective, emergency, young, old people, low and high risk patients. So overall 1.5% risk. The patients who were operated between 0 to 2 weeks, their risk is 4.1%. So this is more than, well, this is almost 3 times higher. And then the risk reduces for the patients operated between 3 and 6 weeks to about 3.6, 3.9%. And then the patients operated at 7+ weeks, their risk is again 1.5%, so it's back to baseline. So, and these rates I've just quoted to you, these are adjusted rates. So we've adjusted these for age, sex, ASA grade, indication for surgery, grade of surgery, sort of minor versus major surgery, cardiac risk index. So even after we've adjusted for all these factors, the patients operated between 0 and 6 weeks are more than double, 2 to 3 times higher risk of mortality. So it's a big difference.
Yeah, huge difference, and it's interesting to see it return to baseline at the 7-week mark. And the causes of mortality in these patients?
So we haven't got granular data to address that, but we know from our previous studies that there's a very strong association between SARS-CoV-2 infection, pulmonary complications, and death. So these patients have a high rate of pulmonary complications, and again, they have if they develop pulmonary complications, those patients have a higher rate of mortality.
In addition, was there any difference calculated, if you have those data, as to asymptomatic infection, somebody known to be positive but asymptomatic, versus somebody who was symptomatic and known to be positive prior to surgery?
Yes, so that's a really good question. And I think this was a really interesting finding, because one of the criticisms of previous research has been that maybe the patients being enrolled were only the symptomatic patients, the ones with severe COVID, and that explains their poor outcomes. But in this study, we have collected whether patients, we sort of put them in 3 groups: patients who were always asymptomatic and were picked up on a screening swab preoperatively, or perhaps they tested positive as because a family member had been infected, etc. patients who had symptoms, but those symptoms had resolved by the time of surgery, and patients who had symptoms that were ongoing at the time of surgery. And what we find is that those patients who are asymptomatic, actually they have a significantly increased risk of mortality up to 7 weeks. So even if it's somebody who, to look at them, they look healthy, they don't have any obvious impairments, those patients should wait 7 weeks if possible. And that underlines the importance of preoperative screening to pick those patients up. Again, the patients who had symptoms that had resolved, they were increased risk, but those risks had returned to baseline by 7 weeks. Now, there was this third group, which is a small group of patients who had ongoing symptoms at the time of surgery, and they are the most high-risk group. And even if they're operated at 7 weeks or longer, and they have ongoing symptoms at 7 weeks, those patients are still at very significantly increased risk. I'll just give you the figure, which is 13% mortality in patients with ongoing symptoms at 7 weeks. So this is really high mortality, 13%. So our recommendation for those patients is that you should wait 7 weeks after SARS-CoV-2 diagnosis, but if they have ongoing symptoms, it's likely they would benefit from a longer delay until those symptoms resolve.
Can you define which symptoms? Because people talk about long haulers and chronicity, and it could be things like some memory loss. It could be things like loss of sense of smell. Are you discussing those things, or more like pulmonary symptoms?
We looked at all symptoms. How people have interpreted that is obviously open to question. About 75% of patients who had symptoms had respiratory symptoms. So things like cough, shortness of breath, needing supplemental oxygen. And then that is obviously overlapping with the group of patients that have non-respiratory symptoms. There could be things like fever, there could be all sorts of odd symptoms like you've mentioned. And I think this is a group that will need further study, because in our data set, we're not really able to exactly delineate what symptoms they had precisely at 7 weeks and ongoing. As you mentioned, there is this growing body of knowledge about long haulers, long COVID, as we call it in the UK. And again, that is probably going to be a growing group of patients over time. And so it's going to be important to get better information to inform their care. So I think that's an area for future research.
Well, speaking of future research, a good segue from what we've spoken about into your second recently published paper on SARS-CoV-2 vaccination modeling for safe surgery to save lives. So better than figuring out how long after an infection to operate would be for patients not to have gotten infected to begin with by having been vaccinated. Perhaps you can tell us a little bit about this international prospective cohort study.
So thank you for the opportunity to mention this. The important thing about this study is the data was collected in October, so that was before anyone was vaccinated clinically. So what we've done is we've modeled what we think the impact of vaccination would be based on looking at what are the mortality rates in patients who don't have SARS-CoV-2 versus patients who do develop SARS-CoV-2 post-operatively. So what's the difference in their mortality after we've adjusted it for all the other factors that might explain those differences? And of course, what we find is that SARS-CoV-2 infection is associated independently with a big increase in mortality. Not so much in younger people who are fit, but older patients aged 50 years to 69 years, 70 years and over, particularly if they're having cancer surgery, it's associated with up to an absolute increase in mortality of sort of 15%. So we've looked at, from our data, at what those differences are. We've also looked at what is the rate of post-operative SARS-CoV-2 around the world. And that seems to be between 0.8 to 1.5%, depending on patient age, type of surgery they're having. And we fed this into a model to try to understand, so if we vaccinated these patients preoperatively, they wouldn't get SARS-CoV-2, or at least from the data we have, it's very rare for people to die after vaccination from COVID. So how many people would we need to vaccinate to prevent a death? What we found is the number of patients we need to vaccinate is globally 351 patients to be vaccinated to prevent one death. This is in patients who are aged 70 years and over having cancer surgery. That number increases depending on the age, and also it's a bit higher in the non-cancer patients. So it's not, you won't save a life by vaccinating 10 people. This is something that has to be done at a population level, essentially. However, given the vaccination is essentially something that's happening anyway, our argument is that we should be prioritizing preoperative patients so that they're covered for the period of time when they are both most likely to get SARS-CoV-2 infection, because post-operative rates are generally higher than the community rates. And secondly, the period of time when, if they get SARS-CoV-2, they're most likely to die from it because of the compounding effect of both the SARS-CoV-2 and surgery. So we then went a step further and we looked at how many people in the general population do we need to vaccinate to prevent a death. This was mostly based on UK-based data on infection rates and mortality rates. And universally, when you look within age groups, it's always much more advantageous to vaccinate the surgical patients than the general population. So, for example, if you're vaccinating over 70-year-olds, within that, we would suggest you prioritize the surgical patients over somebody who's otherwise fit and well. And the final point to make is we looked at how this might vary around the world, because the number of people you need to vaccinate to save a life is clearly strongly related to the incidence of SARS-CoV-2. So, for example, in the UK, we had a big wave a couple of months ago when infection rates were really high, so you wouldn't need to vaccinate many people to save someone. In Australia, for example, they have very low rates, and so you need to vaccinate a huge number of people to sort of prevent one infection and one death. So we looked at what impact that would have. And again, regardless of where you are in the world, what your infection rates are, it's always advantageous to vaccinate the surgical patients in preference to the general population. So we believe the governments should prioritize vaccination for preoperative patients, because as well as saving more lives, we think this will probably support a safe restart to elective surgery so that we can start making sure that our patients get the operations that they need.
Hey, you mentioned the over 70 patients. How about younger patients? You have a patient with inflammatory bowel disease who's in their 20s or 30s. Would you apply that same caveat? They should be prioritized?
So we don't have the granularity to look at specific groups of patients within the age group benign surgery. And you're absolutely right that, for example, inflammatory bowel disease patients might be at higher risk than someone having an elective knee operation, for example. So there is some clinical judgment that's needed there. However, I think in terms of prioritizing them against the general population, it is hugely more beneficial to vaccinate a 20-year-old patient having surgery versus a 20-year-old in the general population. 20-year-old in the general population is very unlikely to die as a result of COVID. Clearly it happens, but is very rare. Whereas in a post-operative patient, that compounding effect does significantly increase that risk.
Well, thank you very much, and congratulations on your two very powerful, very compelling studies. I wish you success with continued research and look forward to chatting with you again in the future after some of your additional findings have been published. Thanks for taking your time today to chat with us, and stay well.
Thank you very much. And I have to thank over 15,000 surgeons and anaesthetists who've taken part in this study. It's been a huge team effort, and we're very grateful for everyone who's contributed and made this possible. So thank you very much.